Thank you, Petrina. Look, firstly, can I just share my respect and admiration for our previous speaker, Lizzie, who, being from Tasmania, obviously I know. And yes, if you remember the photograph of a group of people running across the finish line at a fun run, that was me with the beard and the red tutu on. So just if you were wondering. So we come to our closing session for our conference today, and it's my honour to introduce the first of our speakers who will be talking about the latest in CF research, Peter Walk. Peter Walk is the Director of Cystic Fibrosis at Alfred Health in Melbourne. He's a conjoint Professor of Medicine at Monash University. He holds an honorary position as a Senior Staff Specialist in Respiratory and Sleep Medicine at John Hunter Hospital, Newcastle, and is an Adjunct Professor with the University of Newcastle and Senior Affiliate Researcher at the Hunter Medical Research Institute's Immune Health Research Program. But more than that, and more than those credentials, he is so typical of so many of the health professionals that you see that work with the CF community that that's his day job we've just described there. And yet he also does things like he's on the board of CF Australia. The commitment to the CF community and the people he cares for is not just about his job. It goes way beyond that. And I would certainly like to welcome Peter to the stage to kick our last session off. Thank you.
Thanks very much, Scott. Very, very kind words. Really hard act to follow, Jess and Lizzie, particularly given that you've asked me to talk about this topic, and I'm going to talk about gene therapy. I know absolutely nothing about gene therapy. I'm very, very concerned about how this is all going to go. Anyway, let's see. Some disclosures, some of which are relevant here, including having worked with Vertex. So look, we've heard lots of really, really good news, and as a typical clinician, unfortunately, most of my talk is going to be, oh yeah, but there's a whole lot of stuff that's still an issue here and that we do need to look at. So I'm going to use the data registry throughout my talk because it's such a fantastic resource, and it really does summarise exactly what's going on, what's working, and what's not working. So what's working? This is only just fresh off the press, the infographic that comes out for the latest data registry report, so 2023, ink is still wet. Great news, obviously, improvements in lung function, reductions in infections, a remarkable uptake in CFTR modulators that have been rolled out very, very quickly, a phenomenal increase in pregnancy. While the rest of the country may well not be doing their bit, CF clearly is. Fewer lung transplants, which is fantastic. That has obviously been the case for quite some time, and of course the survival statistics as well. So the modulators are fantastic news, but as Petrina did mention, there are people who don't have access to them. Now, the first reason that people don't have access to them is that they are ineligible, and for that matter, a large proportion of these people, they will not work. So that's 342 Australians on the data registry with CF do not have access to CFTR modulators. That's not an insignificant number of people out of the 3,000 that are there. It is roughly 10%. For those who are eligible, you can see very, very high levels of uptake, well in excess of 90%. It's not perfect. There's still a group of individuals there that are not getting access. That's difficult to know why. So let's just take one step back, and unfortunately, you did ask what's ahead, and I am going to have to talk about the science. So we know that cystic fibrosis is a problem of protein expression, and that little protein, which is expressed on so many cells, moves salt and water in and out of cells, and it does so actively. And it is so important in so many ways, but we don't really understand that well. And the modulators that we have work to improve the way this functions. They don't fix it, they don't replace it, they just improve the way that it works, like putting WD-40 on a squeaky gate. So if you have abnormal CFTR protein, you don't move salt and water into your mucus. And that mucus becomes sticky and thick, and it impairs different sorts of function as well. It encourages the deposition of things like iron that bugs really love to grow in. It impairs the ability of inflammatory cells to clear infection when it's there. But most importantly, it gets stuck. And it's as simple as that. It gets stuck in those little airways. And when it gets stuck in those little airways, you get this intense inflammation around those airways, damage and destruction. And that is why you had to do the 30 minutes in the morning and at the night to try and move that mucus up, which was an impossible task. And we knew that was an impossible task, but it would stave off the inevitable. And along comes Trikafta, and by correcting that movement of salt and water into the mucus, it makes it easier to cough up. And so it turned an impossible task into a possible task. However, there are a proportion of individuals, and it's probably around about 9% of the total population, who have what we call as a class 1 mutation. And all that simply means is that the defect which is present there means that they don't make any CFTR protein. So like I said, Trikafta and the other modulators work by improving the function of the protein, but the protein has got to be there. And if a protein is not there, it's not going to work under any circumstances. And if you remember back to high school, you've got DNA that sits in a cell. That DNA has to translate the message into a protein. And it does that by using a molecule called RNA that then allows the assembly of little proteins. That has to go to other bits of the cell called the Golgi apparatus and the endoplasmic reticulum. And not only does it have to put it together, but it has to assemble the protein in a way that the shape will work properly. So it folds these molecules into a certain way that they will function appropriately. And if that doesn't work, it's not going to happen. So for people with a class 1 mutation, they are not getting any protein to the surface of the cell. And therefore, modulators are never going to work for them. There's another important group, and they're almost as numerous as those with class 1 mutations, and they are people who do not tolerate Trikafta. And that is not an insignificant number of individuals. And again, this is information from the data registry. So we had well over 2,000 people for the last 15 months that have started Trikafta. 1,817 of them were able to stay on full-dose Trikafta throughout the entire time of that 15 months. 153 could not tolerate full dose and they had partial doses. 67 could not tolerate it at all and had to cease. 33 could not tolerate it at all and had to go back onto another CFTR modulator. And the main reason people weren't tolerating it was liver dysfunction. There were other things as well, but liver dysfunction was the main reason. So what happened in terms of improvement in lung function, and this is not a perfect and not the only surrogate measure, but it certainly is a good guide. Well, if you're on full dose, your lung function improves. And it improved like the clinical trials said it would. Partial dose, you still had a significant improvement in your lung function, and we couldn't see a difference between those on full dose, and that's a bit reassuring for me because there's quite a few people I've had to put on lower doses than I'd like, though arguably they are still lower. If you ceased, you did not get a benefit. And I guess that's obvious, but there it is. You do not improve your lung function, so that's a serious problem. And if you switch back to another modulator, you also don't see a significant improvement from baseline. So these people are in just as much trouble as those who are ineligible because they don't have a modulator-responsive gene. So what are we going to do about it? So this all comes down to research and the availability of these products, and you've heard about the movement to get Trikafta and other molecules onto the market. This is not an easy process, and it is not an inexpensive process either. And I just thought this was a good slide just to put up there for people to consider. You start with an idea, and you've got to understand the basic research behind it, and all of that work has got to happen. And then that has to move through a process of research and development, which largely may start in the public sector and university sector, but largely to move forward has to be within the private sector to have the funding to enable that to do. And then that moves into preclinical studies like models using cells or animals to see that the drug is safe, that the drug does what you want it to do, that it can do so in a way that is not going to be too toxic. And then finally, if you think that you're onto a winner, you can move through to trials in humans. And this process then also is fairly long and convoluted. So you've got phase 1 trials, which are really safety trials that people introduce a medication, often in healthy controls. They escalate up to a dose to see what they'll tolerate. And if that all works well, they'll move to the next phase, which actually looks to see if it will work. And it's only then that they start using it in someone who's got a disease. A phase 2 trial explores whether it's going to be worthwhile going on at all, and that often requires hundreds of patients, provided you've got an outcome that you can measure adequately. But a phase 3 trial outside of CF often requires thousands of people. It often has to be replicated more than once before regulatory authorities like the FDA or the Australian TGA will actually look at these and allow them to be marketed. So if you kind of think, and this is a little bit inaccurate, what was the journey with CF? Well, to get to a CFTR modulator, we realised that the gene and what the gene did way back in 1989. When we started to identify targets, maybe that was around about 1996 to 2003. And then 2003 to 2009, a flurry of activity with a whole lot of in vitro work, proved concept and found drugs that were likely to work. And the rest is actually super, super fast. So, you know, from phase 1 through to the phase 3 trials was only 2010 to 2019, and the listing happened very, very quickly. Add another 10 to 15 years onto this for most drugs, to be quite frank. That was super fast, but still quite complex. So this is from the US CF Foundation website. It's looking at the drug development profile, the different drugs and therapies that might be there, and looking at different phases that they're in, so you can see what I was referring to. Drugs in preclinical phase, a bit blurry, sorry. Drugs in phase 1 trials, phase 2 and phase 3. Perhaps not as much as we would like, but there is stuff coming through. All right, so to the difficult part of my talk. So gene therapy, let's start there. Obviously for people with class 1 mutations that don't make any protein, we want to fix the genome. Well, we can actually use small molecules to do this without directly improving either the DNA or the RNA within those cells. And in fact, we've been using this for very many years. Tobramycin may actually have some effect in this way. And what it does is it allows for some of these abnormal mutations that cause an inability to read the message, the coded message properly, and just push through anyway. So the message remains abnormal, but it pushes through and allows for production of a protein to occur. Obviously, tobramycin doesn't do it all that well, and so there are some molecules that have been examined. ELOX2 is where I've gotten and stolen this picture from, and a more specific molecule called SRI37240, which may do this a little bit better. And these are all in preclinical, well, ELOX2 is in early phase clinical trials, and the SRI drug is in preclinical trials at the moment. So gene therapy, and I've taken this verbatim from the US Cystic Fibrosis Foundation website, and if you want to actually learn more and probably get a really good idea about this, they've got a great resource there with some really wonderful videos that you can watch, and I would urge you to do that because I'm going to make a real fist of this. Anyway, so we know that our cells contain DNA, and that's a molecule that stores all of our genetic information like a library, and that specific sequence of DNA carries the instructions to make a protein. Now, we've got two approaches to fix this. We can have either non-integrating gene therapy, where a piece of DNA or a correct copy of the CFTR gene, or for that matter RNA, is delivered and corrects things temporarily, but not permanently. So the downside of that is you've got to keep doing it. The good side of that is it's not irreversible, and there's probably several Hollywood movies out there that tells you when that goes wrong. Okay, then there's integrating gene therapy, where you take a piece of DNA and you permanently correct the genetic abnormality which is present there. One off, you're done and dusted for life, but you can't reverse it. And if there are unforeseen consequences, that's very, very difficult, obviously. So firstly, one form, and this is stretching it now, but inhaled mRNA therapy is currently undergoing some early phase clinical trials at the moment. Proof of concept showed that you could do this within cells and transfer the mRNA that would then go and make the CFTR protein very nicely. And there was a trial which has only recently been published using an inhaled RNA therapy called MART that was done in 42 people with CF. They certainly showed that transfer could occur. There were some side effects that were transient but still were present. They didn't demonstrate an improvement in lung function, but that doesn't mean it doesn't work. Vertex and Moderna in partnership have really taken this forward, and you'll remember when you had your COVID vaccines that RNA technology and packaging RNA within lipid nanoparticles is basically how the Pfizer and the Moderna COVID-19 vaccine works. Similar sorts of technology to package and take and deliver that RNA into the cells is being used here, and a phase 1 trial is underway at the moment in adults to look to see whether that can deliver and express CFTR protein. That is recruiting at the moment at the Alfred. Let me know. Similar molecules are being produced by companies such as Recode and ARCT32 as well. Then there's RNA editing. So you might have heard about things like CRISPR, Caspase, and things like that out there. Well, you can go in and you can actually edit both the RNA and the DNA in certain ways in order to make it work without having to change it in any other way. And this is possible to edit RNA within the cell as well, and the repair system is specifically looking at that. Or a variation of this is using a thing called antisense oligonucleotides that bind to mRNA and allow reading of functional CFTR protein as well. And the latter one is undergoing a phase 1 trial at the moment. That all seems really space age, but that technology is currently being used for a rare disorder called spinal muscular atrophy and is absolutely revolutionary for people with this disease that die from progressive muscular weakness. So it is not impossible. Finally, we can directly deliver CFTR DNA to the cells themselves. You can transfer that DNA directly and then it becomes permanently expressed, or you can edit the DNA in place. Now, probably the most advanced of these sorts of approaches is trying to package it within a carrier that will deliver it to the cells. And viruses are very good at getting into our cells and changing our genome. And in fairness, that's probably why we are who we are today. Adeno-associated virus vectors are currently being used in early phase trials. They're aerosolized-based treatments. They deliver these safe, modified viruses to deliver the CFTR DNA to the cells. Very, very early phase at the moment. Not much, and only just a press release in January of this year. No evidence of airway inflammation being present there. Expression within the tissue. And really the next phase is, well, how do we actually know how this is going to work and how do we measure the effects? Really hard questions. All right. Very quickly now, as I move out of the whole gene therapy thing, I did want to just touch on a couple of other areas, particularly trials that are happening in Australia. So this is our trial, the organoid-guided N-on-1 trial, or the Origin trial. So a bit of a plug, we are recruiting now and we are dosing people at the moment. We're taking cells from individuals. We do over a colorectal or a rectal biopsy. We get your cells, we grow them up, and we produce little organoids. The little organoids will last forever, and we can test how well CFTR modulators work in those cells. That way, we hope that they will predict how you respond to that treatment. We did an observational trial using this, so we took organoids in people, and then, of course, along came Trikafta, and we gave that to all of our patients sitting there in our clinic, and the organoids were fantastic at predicting those early responses in terms of FEV1 and pulmonary exacerbations. They would predict how well you would respond, better than any other test that we could see. Probably not practical for everybody to do that, but the proof of concept is they are highly accurate, at least in showing how improvements in CFTR work. So the Origin 1 trial is funded under BEAT-CF and the MRFF, and we are getting people, we get their organoids, we pre-screen them for suitability. Those who are responsive, we then move into a clinical trial to receive treatment with Trikafta. The aim is to demonstrate that the organoids will predict the clinical response in those individuals. And we are doing this in an N-on-1 trial, where the individual will receive Trikafta and receive placebo. And they do that in a sequence that neither the investigator nor the patient knows when that's happening. And we sequence that throughout several cycles, and that way the person acts as their own control, and we demonstrate in that individual that they're getting a clinical effect, and that clinical effect is being predicted by their organoid response. So we know there are still some important challenges ahead. Pseudomonas is one of those common infections. We've seen quite a marked reduction in the prevalence of Pseudomonas, but Trikafta and other treatments don't get rid of it completely. And we've still got around about 20 to 30% of our patients with chronic pseudomonal infections. And we still think that causes a very significant burden of illness. Now, there are several new, though not very many, antibiotics that are becoming available and are active. But I think we need to use these antibiotics in a more inventive way. And you're probably all aware that antimicrobial resistance is really emerging as an important global health problem. And the more these antibiotics are used, the more resistance becomes a problem. So ideas that combine antibiotics with other interventions, such as removing the food source for the Pseudomonas, that is iron, so we add it to a chelating agent, might improve the function of the antibiotics that we have. And again, there is currently a clinical trial underway that uses a preparation of tobramycin together with EDTA that goes and scavenges and takes the iron out of the mucus to starve the Pseudomonas and to kill it. And very recently, we've actually learned that there are antibodies, well, we've known for a long time that there are antibodies that we make against Pseudomonas. We just thought that they were hopeless. And in general, they are. However, we have found this one which is highly protective. And it is possible then to manufacture that and inhale that antibiotic to prevent infections, at least in a mouse model. And you may well be associated with monoclonal antibodies and how they were used during the COVID pandemic, at least initially, but the virus kept changing and that's largely made them ineffective now. However, Pseudomonas doesn't change as quick as a virus. So we'll see how this goes. I've got these slides from Anthony Kitchich. Phage therapy is another thing to think about. Phages are viruses that kill bacteria. Viruses don't care who they kill. They just want to reproduce and replicate. And phage therapy specifically targets the bacteria and can specifically target bacteria such as Pseudomonas. And it is working, isn't it? Okay. They vaguely look like this. Probably a little bit of artistic license here. The virus lands on the bacteria. It injects its RNA into the bacteria. It then goes and changes the bacteria's genome, and they produce little viral progenies that reproduce and cause the Pseudomonas to explode and die. And so, therefore, could supplement the use of antibiotics. These have been around in Eastern Europe for over 100 years, but are only starting to get into Western medicine now as a potential response to highly resistant microorganisms. And so Anthony and his team have recently been awarded a Cystic Fibrosis Research Trust grant to further explore these agents, and they are assembling a library of different phages that are active against these multi-drug resistant organisms. So if you want to send Anthony back to the Sewerage Works, I'd advise you to do that. He'll get some more. Thanks very much for funding that. All right. So finally, I just want to very briefly talk about, well, we can try and fix the gene, there's gene therapy, there's infection. Inflammation is probably important as well. We've just never had any good treatments for it. But inflammation's important, and more airway inflammation in itself causes a lot more damage. And that in itself can drive the disease process. And for everybody there who's got substantial lung disease already, even on modulators, a proportion will have quite excessive inflammation. And those people are more likely to go on and exacerbate anyway. So if we could tone down this inflammatory response, that would be good. Well, for people who've got bronchiectasis not due to cystic fibrosis, there's been a medication called brensocatib, or a dipeptidyl peptidase 1 inhibitor, that doesn't switch off the inflammation, but tones down the neutrophils, which are one of the driving inflammatory cells that cause lung disease. And this recent clinical trial in people with bronchiectasis not due to cystic fibrosis showed that dampening that inflammation in these individuals improved their lung function, reduced their exacerbations, and improve their quality of life. A phase 2 trial is underway in cystic fibrosis now that will have the same sorts of endpoints. All right, so in conclusion, it's obviously been an exciting and a really revolutionary time as things have changed for people with CF. But there are important challenges that remain, especially for those who are ineligible for CFTR modulators or unable to tolerate them. We're on the cusp of very effective gene therapies, very likely. More effective therapies, though, against some of the problems that we've got are just as important, such as infection and inflammation. And so I think there's a lot of work still to do. Thank you very much. Happy to take questions or just...
How good was that? Thank you so much, Peter, for sharing your expertise. We're now at our final presentation. We're going to have a time of Q&A at the end if we have time. I know our speakers have got a lot to share, so I'd like to welcome back our international speakers, Margaret Rosenfeld and Elizabeth Tallis. Please make them welcome.
Well, thank you. Wow, you guys have had a very full day, haven't you? This is great. We're in the home stretch. So I'm going to be talking about CF in the future. And this is a joint presentation, so I'm going to lead things off. And first of all, just to say, what is the future? And so there's different kinds of futures, isn't there? There's the far future, which is like on this map, so far that you can't even see the road. Well, we're not going to talk about that because, to be honest, we really don't know what the far future looks like. But we will talk about the sort of near future, where it's around a few corners and maybe over a hill or two, but we can still see the road and we have a bit of an idea of what that might look like. And you've heard from Dr. Wark already about all of these new therapies that are coming about. And so this won't be so much directly about therapies, but it will be really more about approach to how we will be looking into the future. So I'm sure you've seen this slide before, and it's just a reminder of all the improvements in survival that have happened over the last 80 years since the discovery of the CF gene on the backs of all these new therapies in conjunction with the CF organizations, the CF parents, and people with CF working together with the CF teams. And so now, as you've heard, the median survival for people with CF in Australia is over 60 years of age. And even a few years ago, that kind of goal of 60 years was felt to be, in the future. But the future is here in that way. So the question is this is where we are now, but how do we look into the future? And how can we sort of predict what the population might be like in the next 10 years? Well, one way is actually by looking at what the population is now and looking back a few years and sort of looking at trajectory and saying, if we continue at this trajectory, what might the future look like? And as you've probably seen already today, that we do have real-world data of ETI that comes from countries like the United States who had access to ETI in 2019, which was considerably before we did in Canada and before it was publicly available in Australia. And these studies, these real-world studies, are showing that the improvements in lung function, which we see on the slide on the left, so the improvements in lung function, those have continued over time. And the drop in exacerbations has continued, so it's not just a year, it's now coming up to 5 years. And that the reduction in transplants and the reduction in death rate has persisted. Now, of course, the thing we don't know is we don't know if the short-term future will predict the longer-term future. And we, in a few years' time, when we have a bit more, days under our belt, we might have a better idea of the trajectory is remaining this way. But this is the limitation of what these kinds of predictions show us. The other way of looking at it is doing what are called forecasting studies, and I'm showing the data of a Canadian researcher who has used the Canadian CF registry, which is very much like the Australian CF registry, and has applied some assumptions based on the results of clinical trials and of real-world data to help predict what will happen to the Canadian population over time with access to Trikafta or not, and depending if people are eligible or not, and then running simulations to predict what things will look like in 5 years or 10 years. And this investigator is now setting this up as a web-based model which would allow individual clinics or countries that don't have access to doing this kind of modeling to be able to plug in their baseline data in order to predict into the future. And Sonia and her team used a combination of assumptions based on the clinical trials plus real-world data, and then they ran the model. So what happens to people if their lung function doesn't decline over time? How many people are you going to have going forward into the future? And how many of them will be adults? And what will their levels of lung function be? And that allows prediction of a future population where we can have information about the demographics of people with CF that will allow us to predict and also model for planning. So we have an idea of the size of the clinics we need and the resources we need and the healthcare team members we need, and give us an idea of what the future will look like. And so we've already found this very useful because in Canada, ETI was approved by Health Canada, which is the equivalent of the FDA, but it wasn't reimbursed. So that meant nobody could access it. And so this modeling study was used to publish an article that said, what would be the consequence if we got ETI now versus getting it in 5 years' time? And we were able to show in the model that a significant number of deaths would be prevented by getting early access to ETI, and there'd be fewer transplants, and the survival would be better. And because this represented Canadian data, the organizations that determine if public insurance would fund the medication found this very compelling information, and that allowed early, very quick access to ETI. And interestingly, the predictions that were made at that time have been exceeded. We have had fewer transplants than we predicted. We have had fewer deaths that were predicted. And that's because the assumptions were very conservative. So now with more real-world data, they can make new assumptions that may be more accurate looking into the future. And this is really helpful as we plan going ahead. And this process has been going on in other countries as well. And in the United States, they've been looking at models which has allowed them to have a glimpse at what the pediatric population will look like in 2040. And at the bottom of this slide, there's 3 pie charts, and one of them is from the year 2000, the other one is from 2020, and the one on the far right is from 2040. And this is in the pediatric population, and the light turquoise color represents children with CF whose lung function is better than 90% predicted. And you can see in 2040, at that point, almost all of the children with CF will have lung function greater than 90% predicted, and there's very few with the yellow bar or the purple bar, which represent lung function below 69% predicted. So you can see very, very high levels of lung function going forward. And what we know is that the ETI seems to make a significant difference in the lungs, but we don't know so much about what kind of difference it will make in other complications, such as liver disease or diabetes. And we don't have enough short-term data yet to really accurately be able to predict those things. But certainly the pediatric population will be getting healthier and healthier from a lung point of view, which is really just extending the trends that have been going on before modulators. The adult population is a bit different because some adults started CFTR modulators when they still had good lung function, so they're maintaining good lung function. But other people started modulators, well, they were already on the lung transplant list. And although it seems that all groups, all levels of lung function, individuals, have an improvement as a group, even those people with low lung function, obviously if you start with lower lung function, you're not going to go up to 100% predicted. So the population of adults will be more heterogeneous because people's lung function will still be variable. And that's what's shown on the US CF Foundation model, and that you can see in the bottom right, the pie chart there, over half the people have mild lung function impairment or normal lung function, but there still is around 10% of people who will have lung function below 40% predicted. So this allows us to get a glimpse that there'll be more heterogeneity in the adult population. And of course, adults with CF have had more time to develop complications such as liver disease or diabetes, and we don't yet know what degree of reversibility there might be or improvement there might be. So the adult population will be a bit more complex. We know a lot about CF complications at the moment: diabetes, sinus disease, bowel problems, obviously the pancreatic insufficiency. But it turns out there's emerging problems. And some of these emerging problems are related to the fact that people with CF are going to be aging over time. So they're going to get the same problems that we all get as we get older. But they may have some additional problems that are either related to CF or related to CFTR modulator therapy itself. So for example, we're seeing hypertension or elevated blood pressure, which can be a side effect of ETI. And people with CF on CFTR modulators may gain weight. And the combination of having diabetes, gaining weight, and having high blood pressure puts people at risk for cardiovascular problems in the future. And so we have to screen people and monitor people and treat people to prevent complications as a result of these emerging problems. So some of our treatments have caused problems in the past. For example, our use of IV antibiotics such as tobramycin can cause kidney problems. So can diabetes. So we have to monitor to make sure that people, if they are developing kidney damage, can be appropriately treated. So there's these emerging complications, some of which we're getting a glimpse of, but some will come upon us like with time. And the important thing here is that we have to make sure our data registries are capturing this information, because right now we're really good at capturing the CF complications we know about, but now we have to capture the things that we don't really know about yet, and that will be very important. And so that's why I say in my clinic to the patients, you need to tell me kind of everything that your new symptoms, like even if it's just an observation, like we need to be thinking about what might happen and trying to track things and report things when we see them so that we can share with our colleagues and with the CF community and identify when there may be emerging complications to put them in registries so that we can truly track them. Some of the complications, I don't really consider complications. I mean, menopause isn't really a complication, it's just a getting older thing. But there may be differences in women with CF having menopause perhaps earlier and perhaps having different symptoms, and there's some evidence for that emerging. So again, we have to keep our eyes and our ears open. So you can see that we're at a stage where there's a lot going on right now. There's a lot of good things. We're going to see fewer complications related to advanced lung disease, and that will be good. And we may see less problems with the pancreas as ETI is started in people at younger and younger ages, when there is an opportunity to reverse the damage and switch children with CF from needing pancreatic enzymes to not needing them. So these are good things. There's going to be new things like obesity and perhaps heart disease and kidney disease. And then there's going to be a bit of a big unknown about some of the other complications like the liver, like the diabetes, like the higher risk of cancer. We're not quite sure how that will change over time. So there's new uncertainty in general, but that is also for the healthcare team. And we're still not sure if our current models of care, they don't seem that they would work so well anymore, like they need to be adjusted. We're wondering how we're going to care for larger clinics, and we have to think about planning for that. We have to think, do we have enough team members? Do we have the right sorts of team members? Do we need help from primary care physicians, from pain specialists, from other experts in other areas? And Dr. Rosenfeld will talk a little bit about how will we assess which therapies we still need, because we've added ETI on top of all our other therapies. How do we know what we can take away? And how do we identify people with CF that are at higher risk for some of these complications to make sure that we're screening people and identifying things early so they can be treated? And the problem is we have to make decisions now. We have to look at adjusting the model, but we don't have all the information. And this is where, again, the CF community is important, because the temptation is, when you feel better, is to not want to spend time at clinic, and I can appreciate that. But I think that it's only by interactions with people with CF that we're gathering the information that allows us to work out what the risks are and what do we need to do to follow. And so we're kind of all in a bit of an experiment at the moment of reestablishing like the new environment, the new normal, and we need everybody's help in that regard. And so the framework for going forward is sort of a complex framework. We have to look at what we do now and how we make decisions and our models of care, how often we see people, what measurements we get. But going forward, we have to remember a few key points. There's no question that the CF team is still critical. There's still lots of things about CF that are very specialized, and we need to retain our CF team and their expertise. But we have to evolve the care model to recognize older populations, different complications. And we should leverage technology, and whether that's technology like home spirometry or wearable devices that can monitor things at home, whether it is technology in the form of our electronic medical records that allow us to alert us in terms of how to screen people, but technology is going to be key. And I think the most important thing is involvement of people with CF and their families in developing these new models of care, is hearing from people with CF about what are the challenges and the barriers to the current model with how they're feeling, so that we work together to try and find a model that reduces the burden for people with CF, but we don't want to go too far the other way. And we would hate to be in a situation where we were underdiagnosing things and missing things that we could be treating. So it's this balance that we have to find. And then other things that Dr. Rosenfeld will be speaking about is we have to recognize that there are still inequities in CF care, less so perhaps within countries where there is access to drugs like ETI. But even within our countries, there are inequities that can impact the outcomes of people with CF, and we should work to make sure that we diminish those. And then we have to look forward to how do we sustain this model? And in healthcare systems that are always looking to cut costs, how do we make sure that our CF team is still intact and still able to help people with CF live their best lives? So basically, we need a new roadmap, and I think maybe it doesn't look like this. Maybe it's more a GPS roadmap, and our horizon is down the road about 10 years, and with this new roadmap that we'll work together to create together, then that will guide us for the next piece of the road, while we collect the information that might give us an idea what the further future looks like when the treatments that Dr. Ork was talking about, when those can come into play and we see further improvements in the care of people with CF. So now I'll pass over to my colleague for part 2.
Okay, hold on. There we go. Good afternoon. So I'm going to be continuing this discussion about looking into the future. Some of this is a little fanciful in my own personal interpretation, but I'm going to be focusing on 3 broad areas. The first is simplifying treatment burden. The second is health equity, and the last one is advocacy. So as we talked about this morning, simplifying treatment burden is a really top priority for people with cystic fibrosis, and we hear you, and there is a lot of active research in this area, especially in people who are taking Kaftrio or ETI and may be able to substantially reduce their treatment burden. So right now, you're all way more familiar with this than I am, because many of you are living with this every day, but there's really an incredibly heavy daily treatment burden, which is consisting of oral medicines as well as inhaled treatments and chest physio that take hours each day. And these have dramatically improved quality of life and prolonged life, but at an expense of feeling overwhelming much of the time. So what might the future hold? There's been a little bit of work in this area and then a burgeoning amount of research moving ahead. And the first landmark study in this area was called the Simplify study, which was conducted by friends and colleagues of mine in the United States and has since been published, and I'm sure many of you are familiar with it already. This was consisted of 2 parallel open-label randomized studies at 33 sites throughout the United States. And it enrolled people who were over 12 years of age, already on Kaftrio, who were either taking, I don't know what you call it here, Dornase or Pulmozyme, or hypertonic saline, or both. And then they were randomly assigned to either withdraw treatment for 6 weeks or to continue it. And people could actually enroll in both studies, one after the other, if they were on both agents. And what we saw was that stopping therapy really did not cause any change in lung function at all. So over 6 weeks in people over 12 years of age with relatively healthy lung function, there didn't seem to be any bad side effects of stopping hypertonic saline or Dornase. And there were some other endpoints that also looked very safe. This is another more sensitive measure, the lung clearance index, which also didn't show any change over that period in time. So this was an incredibly rigorous, large, well-done study, but it only answered one of many questions that we still have. So this will be a very active area of research as we start to look towards the future and what can CF care look like. First of all, we need to understand, is it safe to stop inhaled therapies for more than 6 weeks? What about for the rest of your life? Is it safe to stop therapies in younger children? Do these therapies even need to be started in really young kids in whom we would typically be recommending starting them somewhere between 3 and 6 years of age to slow disease progression? Is it safe to stop them in people with advanced lung disease? What about chest physiotherapy? That's one of the most burdensome ones and also one of the most very challenging to study. What about chronic inhaled antibiotics? Now that people are so healthy they aren't expectorating anymore, it's often hard to know what germs are growing in the lungs, which makes this question especially challenging. And then there are the very burdensome non-respiratory therapies. What about pancreatic enzyme replacement therapy? Can it be reduced or stopped or maybe not started if people start on ETI at a very, very young age? What about insulin? What's the effect on the ability to decrease the dose or even stop insulin altogether in people who have diabetes? And how do these questions have different answers depending on how old you are when you start Kaftrio and what stage of disease you're at? So this is just my kind of fun thought about the future, maybe 10 or 15 years from now, what the future might hold. So I think it will hold a very personalized approach to these chronic therapies, and that this will be based on many features about an individual person with CF. The age at which they started Kaftrio, and in my mind, will also at that point have genetic therapy so that everyone will be able to avail themselves of some sort of life-changing therapy that makes a huge change in the actual CFTR protein function itself. And that we'll be able to have a unique individual risk profile for each person with CF that really, this is my fanciful idea, could be based on biomarkers, maybe in blood or exhaled breath, new imaging techniques, new lung function tests, ability to look at a very personal level at environmental exposures that are identified by personal monitors, maybe that we have like on a wristwatch, thinking about all these things that are affecting us in the Western United States as well as you here in Australia, wildfires, air pollution, extreme weather events, so that there may be times of the year or seasons in a person's life where it makes sense to be on these therapies and other times when they can be held, and that we'll be able to really tailor the need for these burdensome therapies to each individual person. It's also kind of fun to think about how we might be able to use technology to help everyone to remember to take all their medications, even if the burden is less than it is now. So I think maybe we will have AI-enabled personal assistants that can remind us to take our medications without being persistent and obnoxious. So we'll see if that comes to pass. So switching gears into the last part of my presentation, I really want to talk about a future where no one with cystic fibrosis is left behind. So as we've been talking about so much, it's really a time of great optimism in the world of cystic fibrosis with improved outcomes for so many members of the CF community. But we have to remember that this new era has forced us to reckon with the huge global disparities in CF diagnosis and also access to CF care and life-changing therapies. And that even in countries like Canada, the United States, and Australia, where there is access to ETI and other really important therapies for people with cystic fibrosis, there are members of minoritized groups that are less likely to be eligible for ETI, and even if they are eligible, may be less likely to either be prescribed or decide to take these therapies, so that there's a lot of work to be done all around the world. There have been some really important publications over the past few years that have shown us that CF is absolutely a global condition. So a recent paper estimated that 112,000 people around the world currently have a diagnosis of cystic fibrosis in 95 countries. And furthermore, this is the really shocking part, that there are probably about 77,000 people in the world right now who have CF but don't know it. They're undiagnosed. And that, of course, means they can't have access to any CF care, let alone life-changing therapies. And that the vast majority of these people live in low and middle income countries, particularly India, but also many other low and middle income countries. So that the total expected CF population is the 112,000 who carry the diagnosis, plus 77,000 people who have it but don't know it, leading to a global burden of CF of pretty close to 200,000 people around the world. And 41% are probably undiagnosed, and almost all of them living in low and middle income countries. So that's kind of a shocker, I would say. Probably there are more people living in the Indian subcontinent than there are in the United States with CF. They just aren't aware of it. So what can we do to improve the diagnosis of cystic fibrosis in countries in which it's not known to be such a prevalent disease? First of all, support awareness of CF around the world. Encourage CF newborn screening in particular in countries that do newborn screening. Of course, most of these countries don't have established newborn screening programs. Develop better sweat chloride testing methods. Develop genetic testing that really picks up the variants that are seen in all these different populations. So a lot of work to do there. And then we have to think about how to help our partners in low and middle income countries have better access to care and to life-changing therapies as well, which we can talk about in the Q&A if there's time. But I did want to switch gears and talk about health disparities in the United States in terms of access to Kaftrio. And you've seen a little bit of the same here in Australia, though the profile is a little bit different. So in the United States, we have the majority of people with CF are Caucasian or non-Hispanic white, but about a quarter of children with CF fall into other racial and ethnic groups, particularly Hispanic, but also Black and Asian. And then about 12% of adults also fall into these minoritized populations. And you can see that in the United States, pretty close to 90% of people who are non-Hispanic white, or what you might call Caucasian, are eligible for Kaftrio based on their genetics. But that goes all the way down to 40% if you're Asian and 57% if you're Black. So most unfortunately, those who are not as likely to be eligible for Kaftrio are the ones who have already had so many issues in terms of inequities in care even before Kaftrio came along. So I wanted to end with a real pitch in terms of advocacy, and I just wanted to give an incredible heartfelt thanks to Jess and to Lizzie for their presentations. They were so inspiring. I needed a box of Kleenex myself as well, and I had a chance to talk to Mitch, and I know that there are many others in this room who have really already engaged in advocacy, and my pitch is let's all work together to ensure that there's better access to CF diagnosis, care, and life-changing therapies all around the world. So there are many initiatives to develop disease-modifying therapies for all people with CF, and we heard about many of these different kinds of genetic therapies, as well as newer CFTR modulators. And Dr. Work did a great job, though he didn't have a lot of confidence. I can say 11 out of 10, great job, in explaining these different kinds of therapies. And I really think that, you know, they're not an easy fix. They're going to be a long-term solution, but I have every confidence that they'll become available. I'm not going to give a time frame here. We also really need to address causes of poor health outcomes in minoritized people with CF, trying to deal with things like structural racism, implicit bias, medication hesitancy or trust in the healthcare system, financial access issues, barriers to care of all different types, and really importantly, the poor representation of minoritized groups in clinical trials. That's something we really, really, really need to work on. So, in terms of thinking about what the future will hold with a health equity lens, we all need to commit to a future in which all people with CF in our countries, in low and middle income countries all over the world, can live healthy lives and have access to life-saving therapies. And the CF community can do so much to make this vision a reality. You guys have such a powerful voice, and we can partner with our colleagues all around the world and CF communities all around the world to really make a difference. We can raise awareness of these health equity issues in our own countries and around the world. We can help to make sure that the voices of all people with CF are heard. And we can partner with nonprofits like CF Australia or the US Cystic Fibrosis Foundation and many other entities and governments to reduce costs and increase access to disease-modifying therapies. And there's some really, really powerful CF family organizations, particularly out of Europe, that have been incredibly vocal, held protests, all sorts of things to demand that there be broader access at a more reasonable cost to the current modulators. So I really want to end by saying your voice matters, and let's partner and get the job done. Thank you so much.
We literally have about 4 minutes to take some questions because the Centre charges by the hour, or the minute, I'm told. So have we got any questions? Here's a microphone. So do we have any questions for Margaret, Elizabeth or Peter? Yes, one over to Jess.
I have a question about, you were mentioning the complications of Trikafta, and obesity was one of them. Is that because as CF patients growing up, we've always been told to have that high-fat, high-calorie diet? When we go on Trikafta, is it because people are continuing that diet, or is it Trikafta actually contributing to the obesity when people just haven't come off that diet?
Is that better? Yeah. I think the answer is sort of yes to all. So I think that it does appear that people on Trikafta have an increased appetite. And so there may be something happening at a central level in the brain that your sensation of being hungry is increased. But the legacy diet or the traditional high-fat diet, when you take Trikafta and your intestinal absorption, your pancreatic enzymes work better because you are pH balance in your intestines better, so the enzymes work better, so whatever you eat, and if you take the same amount of enzymes, you're absorbing more of the calories. So if you're more hungry, you're eating more, you're absorbing more, and you're sticking to your diet that's been a lifelong diet that's high in fat, the end result will be weight gain. So not all people with CF on Trikafta will gain weight, but a great number will, because of all those reasons.
Another question? We've got time. Yes.
How can we go about, or how can we help, given the talking about advocacy, translating that into access if you do find positive effects?
Yeah, so we're going to need that if once we've got that trial data. We've had to pay for Trikafta for this trial. That was the single biggest expense of the whole trial, was giving people enough Trikafta potentially for 16 weeks, and we can only afford 20 patients to go through that. Once we're finished with the trial, people are not going to get any Trikafta after that. So the next step really will be, look, we have a mechanism to identify someone is responsive. We need to be able to then get Trikafta for those individuals. At the moment, the reimbursement is purely based upon genotype and a diagnosis, and there is no way easily to access it beyond that. And the steps to add more genes kind of come, but come very, very slowly. So I think we need a much more agile and sensible approach to how the medications are being used, and how and how access to the medications can be available. And given the scale and the size of the population, the specifics of it, but also the expense, I don't think that's unreasonable. And the rules that it has to be relatively simple, lots of doctors have to be able to understand it, the process needs to be, but that's all not relevant to this area. It can't be the same, and there's too much of a feeling, oh, it's just another drug and we're going to treat it the same as every other drug. And at the moment, people are missing out. there are people who are probably not getting that much benefit out of it either, potentially. So it works both ways.
We have time for one last question. Does anyone? Yes, first hand I saw.
Thank you, and thank you to everybody for today. It's been really informative, interesting, and inspiring. There's been a lot of talk about Trikafta and obviously the benefits that most or lots of people are finding from taking it. We've talked about a few of the side effects in terms of with liver function, maybe with the intolerance. Haven't heard an awful lot today about people's comments about behavioural changes to taking Trikafta, and wondering if there's anything concrete about that, especially around the children starting to take it now.
That is really $1 million question. So I think there are more and more published studies coming out that on the whole, like if you look at averages, there's not a clear association between starting Trikafta and mental health outcomes. However, it seems clear that there is in some individual patients. That just seems abundantly clear. With regards to kids, I think it's something we need to be especially cautious about in the developing brain and over the long term with exposure for many years. So there are many of us who have advocated for randomized controlled trials to try to better understand the outcomes, adverse outcomes on mental health or behavior or attention deficit hyperactivity disorder, those kinds of things in kids. And so far that has not been met with lots of enthusiasm on the part of the modulator companies, but hopefully going forward we'll be able to collect more data. And I think that's an area that's of great importance to the whole CF community that is not clearly straightened out yet.
Look, thank you. Oh, sorry. Did you want to just chime in?
I only wanted to say it's just been so difficult to sort out in part because of all the things that have happened at the same time. You know, the COVID pandemic and lockdown and mental health problems were being documented in the whole population, but also in the CF population before modulators were available, except early in the United States. So it's really hard to tease out, and so the comment about the need for clinical trials to look at this, because that's really the only way that you would really answer that question.
Thank you. Look, I really will have to bring it to a close today, but can I get you to please give a generous round of applause to our speakers, Margaret Rosenfeld, Elizabeth Tullis and Peter Walk. Thank you very much. We are at the end of today, and I've been given the task by Joe to summarise today, which is no biggie, and I've been given 60 seconds to do it. So here we go. A presenter today, earlier, made the comment, I can't remember who it was, that this conference, and I'm talking about the medical conference as well, seemed to have had a positivity and a vibe to it that they'd not seen before at previous conferences, a sense of hope and optimism about the future. And maybe that's due in no small part to the arrival of modulator therapies that are transforming the lives of many people with CF. But it got me thinking, respectfully, to people that live with this disease, is this a good time to have CF? Or at least, has there ever been a better time to have CF? And I think the answer is yes and no to those questions respectively. I'm not suggesting that life for anyone with CF is easy, but in this country, one of my takeouts from this conference has been that we have so much to be grateful for, and it's not just about modulator therapies. We have newborn screening, we have genetic diagnosis, we have well-resourced multidisciplinary teams around the country. We have a data registry. The clinical model that we have, if not unique to CF with multiple disciplines, is certainly rare. And we have a public health system that means that we have access to care regardless of your health insurance status or your socio-economic status. We also have a capable and resourceful CF support and advocacy organisations around the country, a federation of CF organisations that work together. So I think we are doing well in Australia, but of course we can and we must do better. And I suppose what I've heard is that For all the recent advances in CF care, the job is not done. We don't need to shutter or wind down our clinics just because modulator therapies are here. CF care is becoming more complex and more nuanced as people with CF are living longer and we have more heterogeneous adult populations with CF. And there's still going to be a need for advocacy, a data registry, and for CF conferences. And with that in mind, I'd like to invite you to join us in 2 years' time in Victoria for our next Australasian CF conference. I look forward to seeing you there. And to have the last word, I was going to cheekily say, as she always does, no. Can I welcome to the last time to the podium Dr. Jo Armstrong. Thank you very much.
The last word. Thanks, Scott, and thanks everyone for being here today. It's really wonderful that we've been able to have this time together. I hope that you got a lot out of the sessions today. I'd like to sincerely thank all of our speakers and presenters, all of our chairs for the sessions today, all of the committee members that spent so much time bringing the programme together, the CFA team, Nikki and Bianca, thank you so much, and also the team at Icebergs, Katie and Mika, thank you as well. Thank you to our Federation members. Really appreciate you all coming together to make this possible. You will receive a survey in your emails asking for your feedback. As always, don't hold back. Really, your feedback helps us inform what we do in the future. Don't forget to grab a photograph at the photo wall before you leave. There is a competition to win a ticket for the next conference. You just need to upload it to socials and tag us. There's details out there. And that concludes our conference, and we'll see you in Victoria in 2026. Thank you.